Okay.
So good morning. Once again, thank you. My name is Brooke Oliveri. I am the manager of the Long Island Health Collaborative. And I would like to welcome you to Talk with a Doc, Migraine and Headache, with Dr. Bruce Mayerson of Catholic Health. So for those of you who may not know, the collaborative is a group of 300 plus hospitals, community-based organizations, local county health departments, and other organizations from all sectors really who are invested in improving the health of Long Islanders. I do want to thank AARP New York for sponsoring our 2023 Talk and Walk with a Doc series. And before I hand it over to our virtual ambassador, just some housekeeping. We are recording today's program. We will have some pre and post-event poll questions for you to answer. And we will also have a robust Q&A with Dr. Mayerson at the end of the program. So please, if you have a question, feel free to put it in the chat, write it down, or hold it till the end, and we will certainly get to those questions you may have. So now I would like to introduce Elaine Goldsmith, our AARP volunteer and virtual ambassador, to say a few words about AARP. Oh, you are muted, Elaine.
No. Okay, sorry.
That's
Hello,
okay.
My name is Elaine Goldsmith. I am an AARP volunteer and I live in Melville. On behalf of AARP New York, welcome to today's Talk with the Doc virtual wellness webinar. We are committed to helping you stay connected, so we congratulate you for taking the time to grow, create, and learn with AARP and the Long Island Health Collaborative. As you know, AARP is a nonprofit, nonpartisan membership organization for people age 50 and older. There are 38 million members nationally, 2.4 million in New York State, and close to 500,000 members living and working right here on Long Island. AARP works to strengthen communities and advocate for what matters most to people 50 and over and their families, with a focus on health security, financial stability, and personal fulfillment. Here on Long Island, AARP staff and volunteers work together to ensure our community is a healthier, friendlier, more livable place to work, play, and explore for people of all ages. And we work closely with community stakeholders to make our community an even better place to live. Learn more about other online classes, virtual events, local discounts, volunteer opportunities, and more at aarp.org/local. Thank you for joining us today.
Thank you so much, Elaine. And once again, thank you, AARP, for sponsoring this series. We are so excited to have them on board. So before we get to Dr. Meyerson's presentation, we do just have a few pre-event poll questions for you to answer. I just went ahead and launched those now, if you wouldn't mind taking a moment to give us some of your feedback. These questions, we use them to not only shape future programming, but to get a sense of your impressions before and after the education that we provide. So your feedback is very important to us. So you should be able to see those poll questions now. I will give it about a minute here for everyone to respond. And some feedback we've gotten on these questions in the past, like for some of the questions regarding today's topic, you might not be sure of whether you're able to adopt some of the tips in today's program, but that's okay. It's really more of a sense of where you are, personally. So thank you for your responses. I do see them coming in. And I'll just give it maybe 30 more seconds here, so everyone has a chance. Oh, it looks like everyone has answered. So thank you so much. I'll close the poll out here. And now I would like to introduce Dr. Bruce Mayerson. He is the Chief of Neurology at St. Catherine of Siena Hospital, and he is part of Catholic Health Physician Partners Medical Group. And he is going to be speaking about migraine and headache today. So without further ado, I'd like to hand it over to Dr. Bruce Mayerson.
Good morning, everyone. Okay. So I was asked, am I visible to people? Because I don't.
Yes, we can see you and we can hear you.
Okay, good. So we were asked to talk today a little bit about migraines and headaches, and in the interest of time, the presentation of this will be kind of quick, and then hopefully we can get into some question and answer type situations. Migraine is probably one of the most common, if not the most common, headache syndrome. Is definitely the most common headache syndrome that we see in general, and one of the most common reasons for neurological consultation, either in the office or in the hospital. Migraineurs, migraine is a chronic disease, and it is intermittent, and people who come to be seen for migraine headaches in the office are generally patients who've had migraines with increasing frequency or severity and are wondering if there's anything that can be done to prevent them and to treat them if they should occur. In the emergency room, people who have severe headaches often are diagnosed with migraine, or known migraineurs who come to the ER because they require more advanced treatment, often with intravenous treatments for acute headache management. Migraine is very common, occurs probably in 12% of the U.S. population. It's more common in women than men by a ratio of probably about 3 to 1. It is important, I think, to note that a migraine is not just a bad headache. And I think that that's a misconception that we hear out there a lot when people discuss these things. They'll have a bad headache and say, oh, I'm having a migraine. A migraine is a syndrome for which headache is just one symptom. It's the most common symptom, and it's often the most debilitating symptom, but you can actually have migraines without a headache. So I think we have to sort of dispel, from the notion that migraines are just a severe headache. That's again, headache is one of the symptoms and often a defining symptom, but often other symptoms are present, and we'll get into that a little bit as the talk goes on. As far as causes of headache, causes of migraine go, I should say, we don't know exactly what causes migraine. It has to do with activation of what's called the trigeminal-vascular system that causes a multitude of symptoms, as we will discuss. There is definitely a genetic predisposition to migraines, and family history is very common when we're talking about migraines. Sometimes you have to dig a little bit deeper, because if you just ask about headache, you may not get the other symptoms that we often see. Causes, again, probably a combination of genetic and environmental, as with many diseases, but there are certain things that trigger migraines in patients. Common things such as stress, hormonal fluctuations. They're common with women around their menstrual cycle. We call that catamenial migraine. It can occur with sleep deprivation or excess. It can occur with triggered by physical exertion. Sometimes red wine triggers it. Caffeine withdrawal can trigger it. And certain weather changes in barometric pressure and temperature changes and humidity changes are frequent triggers, as are sometimes bright lights, certain smells. So these are all things that migraine patients are aware of, and if a specific trigger applies to them, are things that they try to avoid. Migraine headaches or migraine often is occurred, with a prodrome of fatigue or mood change, or just kind of feeling lousy and malaise. And then if you have what we call migraine with aura, you may develop neurological symptoms like flashing lights or zigzagging lights. And you may see flashing blind spots in different areas of your vision, which can last, anywhere from several minutes, 5 minutes to a half an hour, sometimes even a little more, and then be followed by headache, or the headache can occur first, and then those symptoms can develop. Common migraine is the migraine that is not associated with any of those prodromal type symptoms with the vision and that sort of thing, whereas classic migraine common migraine occurs in about 80% of patients. About 20% will have some of those auras. The auras do not need to be limited to visual symptoms. Those are just the most common that we speak of. Patients can have focal neurological symptoms and even mimic stroke-like symptoms, including loss of sensation on half the body, weakness on half of the body. Patients can have vertigo associated with migraine. So really, any common neurological complaint is one that can be associated with migraine, to be followed by or preceded by headache. And the headache is usually the most debilitating symptom, because associated with it is severe nausea. Patients will often vomit and need anti-emetic drugs to alleviate that. And they're also associated generally with significant sensitivities, and certain sensitivities to light, to noise, to smell. It could be any one of those three things or not. And the headaches generally are unilateral, but they can be on both sides, but usually it's one side. They can alternate sides sometimes, although a lot of patients have always the same sided headaches. The headaches are throbbing in terms of the quality as opposed to dull. The headaches are sorry, I lost my train of thought. The headaches are aggravated often by physical activity. And patients who get migraines, and if anyone out there knows patients, and I'm sure you do, often their instinct is to go into a dark room, turn off the lights, get away from everybody, and just kind of be alone, put the covers over their head until the pain and the light sensitivity, noise sensitivity resolve. Generally speaking, migraines last on the order of several hours. As far as diagnostic criterion, the headache should be present for 4 to 72 hours. And typically they last a better part of a day for patients, and they really can wipe patients out for a day if it's a bad migraine. Headaches that last more than 72 hours, or migraines that last more than 72 hours, are a special breed. We call that status migrainosis, and those patients often need emergency room evaluation so that they can be treated frequently with intravenous drugs. And I think that and I mentioned also the family history is often positive in patients with migraine. You frequently will have other first-degree family members, and sometimes a bunch of them who have a prior migraine history. I think the first thing to do when you're seeing a headache patient in general as a neurologist is to get a good history and make sure that the things that I just mentioned are present before making a diagnosis of migraine. There are other more dangerous things that cause headaches that are not migraine and have nothing to do with migraine. So that emphasizes again the point that headache is a symptom of migraine, but it's not the only symptom, and all headaches, even severe ones, are not migraines. And you need to seek attention with your medical professional if these are new onset headaches, for you to make sure that you're not missing something else.
Mhm.
Oftentimes people wind up having their head imaged with either a CAT scan of the brain or an MRI, but they don't necessarily need to. And certainly if they have a long-standing history of migraine, they don't have to be imaged every time they have a headache. Finally, as far as treating migraines go, there are two ways to treat migraine in general. The first way is with a daily preventative headache medication, which is something that you take every day, whether you're having a headache or not, to decrease the overall frequency and severity of the headaches. And there are several different classes of drugs that we use. Among them are anti-seizure medicines like Topamax and Depakote, tricyclic antidepressants like nortriptyline or amitriptyline, beta blockers, drugs like Inderal, and which is propranolol, and calcium channel blockers are the main classes of preventative drugs. We also use a newer class of antidepressants called SNRIs, drugs like Effexor and duloxetine. And typically we reserve those options in terms of treatment for patients who are having 3 or more incapacitating headaches a month. But that's just a guideline, and there are some people who, only have 1 or 2 really bad headaches that wipe them out for several days and want to be on daily preventative. I have other patients who get 5 or 6 headaches a month, and they just prefer to take something as needed and not be on a daily medicine. So it's really a very patient-specific preference. And as far as breaking headaches, migraine headaches go, the first drugs of choice generally are over-the-counter anti-inflammatories, naproxen, ibuprofen, things like that. Tylenol is often used, but there are more migraine-specific medications, including the triptans, which are the older class of migraine-specific headache medications, and the newer class, which is what's called the CGRP antagonists, and those are drugs that you may see on TV with some frequency now because they are being advertised a lot. They are the newest class of drugs, including drugs like Ubrelvy and Nurtec, which we call the Gepants. More severe or protracted headaches that don't respond to those at-home medications will often require an emergency room visit where intravenous drugs are used, including steroids, Depakote, drugs like Reglan, and anti-nausea medications. And amongst all of those, we're typically able to break a headache, and a protracted case of status migrainosus is a pretty rare thing. Happens, but usually we're able to take care of them if they are to the point where the patient requires an emergency room visit. Migraineurs, but certainly migraine with aura can be associated with other neurological issues, including an increased risk of stroke and what's called a PFO. So those patients often, have to be monitored, and certainly if their symptoms don't get better, their aura, they need to be imaged and make sure that they have an acute brain event. And that's pretty much it in terms of my talk. And I guess we'll now open the floor to questions.
Great. Thank you so much, Dr. Mayerson. Super insightful. I used to have migraines with aura, and I learned a bunch from what you just discussed. So you can feel free to unmute yourself. I also see some questions in the chat.
Am I muted?
No, you're not. Just
sorry.
the attendees, they can unmute themselves if they'd like to ask a question aloud. My initial question, I was wondering if you could touch on prevention. Is there anything that we can do, in our daily lives to prevent migraine and headache?
Well, telling you to reduce stress, I think is as an example of something to target potentially is a great thing to recommend. But how do you reduce stress in your life? I think that's difficult depending on what your circumstances are. So there are certain things that can be, avoided in a patient if those things trigger migraine. But if you're prone to, menstrual migraine, or catamenial migraine, we can't stop you from menstruating. So, there are certain things that, can't be avoided, but triggers that can be avoided are among the things that I mentioned, things like skipping meals, dehydration, as I said, stress. Hold on one second,
Sure.
because I just lost my, okay, sorry. Things like
Right.
stress, avoiding things that trigger them in you are things to avoid. But not every migraineur is triggered by sleep deprivation. So for you, that may not be an issue. If it is, then those are the sort of things that you should avoid. In your day-to-day life. Again, I think it's very patient specific, because truth is you don't need any trigger. Migraines can just happen seemingly out of nowhere. So if there are specific triggers that are a problem for you, those should be avoided. But sometimes it's not enough.
Thank you so much. I do see some questions in the chat. Someone asked if the headache resolves with a triptan drug, would that confirm that it is indeed a migraine headache?
That would be it's not absolutely diagnostic, but that would be the most likely reason for that type of headache. The triptans are, migraine specific drugs, and they can be used to treat other syndromes, such as cluster headache, as an example. So it's in terms of common things happening commonly. If you have a headache that otherwise sounds like a migraine, and you take a triptan, and it gets rid of the headache, there is a very high likelihood that that's what you've got.
Thank you. I know you just touched on prevention, and of course it is different for all patients, but I do see this question in the chat. What are your thoughts on the 30 days subcutaneous prevention for someone with 7 to 10 migraines per month?
So yeah, I neglected to mention that, and I should have, in the preventative medicines. There are several new drugs as well, in addition to the other ones I described, the anti-seizure medicines, the antidepressants, that are calcium channel blockers that are given intravenously on a monthly basis, one every 3 months. There is another one that can be used every 3 months, and those are very good. Typically, to get insurance, you only need to take them once a month, and they are an injectable, and you have to be able to inject yourself or have someone inject you. Often, we find that before getting insurance to authorize those medications, which are relatively new and expensive, the patients will have had to fail a more traditional treatment, one of the other medications. So.
Sure. Okay, thank you.
Go
ahead.
One other thing I neglected to mention, the key with treating migraines when you get a breakthrough is that the medicines, whether it's a triptan, whether it's an anti-inflammatory, whether it's one of the CGRP antagonists, they need to be taken at the very onset. Because if you wait for them to get really bad and see if it's going to become a migraine, you may miss your window. So treating the symptoms during the prodrome is really the best time to attack them.
Great to know. Someone asks, can birth control contribute to migraines?
So the relationship between birth control is it has to be discussed in relation to hormones, estrogen and progesterone, and birth control pills per se don't cause migraine, but There are patients in whom we use birth control or might, if other things have failed, stop birth control to see if that can affect the frequency of somebody's headaches. Again, this is tied in with hormonal changes with estrogen in particular, and patients who have menstrual migraine. There is a very strong, hormonal component, but I wouldn't say birth control is a cause of oral contraceptives or a cause of migraine.
Very insightful. Thank you. I don't see any other questions at this moment in the chat. If you do have any, please feel free to put them in there. We do just have some closing tips and laws for walking safely. The Long Island Health Collaborative, we promote walking as a way to combat chronic disease. As Dr. Mayerson said, reduction of stress can be helpful in avoiding migraines. So walking is a good way to relieve some stress. Pedestrian injury and fatality is quite high on Long Island, so we just remind you to please always use the sidewalk. If there is no sidewalk, always walk facing traffic, which is the law. And some tips: see and be seen, cross streets and crosswalks, don't text or talk on your cell phone while you're walking. And for more information, you can visit walksafeli.org. And now we just have some closing poll event questions for you, if you wouldn't mind responding. They're really the same questions that we asked in the beginning of the program, just to gain a sense of your impressions after the program. And while you're filling those out, I just want to thank everyone for your attendance. Thank you so much, Dr. Mayerson, for taking the time out of your day to educate us and answer our questions today. And thank you so much to AARP for sponsoring this series.
Great. Thank you so much.
Thank you.
Bye.
Bye-bye. And I'll just remind everyone that we have one more talk in the series coming up on June 21st, and we have an in-person walking event that we are hosting on June 24th, and we would love to see you there.
Thank you. Excellent.
Thank you all so much.
So I am going to this.
Okay. I'm going to close the poll here and end the meeting. Thank you all very much for your participation.